We have been discussing about the peripheral arterial system, and we have discussed about the stenosis, the occlusions, and ultimately the gangrene and the conditions leading to the amputation in the past couple of lectures. Since this is the continuation of the vascular portion of the general surgery, so we'll be talking about the arterial aneurysms and how they are going to be generated, we'll be discussing today. So if we particularly talk about how to define the aneurysm, so always keep in mind that if there is the dilatation of the arterial system, the localized dilatation of the arterial system is particularly called as aneurysm. But you have to differentiate between the ectasia and obviously the dilatation or the aneurysm. So if the dilatation is involving greater than 50% of the localized arterial system, then this is particularly called as the aneurysm. And if we talk about the ectasias, and if it is less than 50% of the localized arterial system dilatation, then this is called as the ectasia. So first you need to differentiate between the aneurysm and the ectasia. So that if the localized arterial system is involved, there is a dilatation, and the dilatation is greater than 50%, then this is called as aneurysm. And if the dilatation is less than 50%, this is called as the ectasia. So there's an image coming onto your screens. If you could appreciate, this is actually obviously the arch of aorta, and arch of aorta, is coming from the left ventricle, and there are a number of the branches which are coming from the arch of aorta, like the brachiocephalic trunk and the subclavian, and they are giving the arterial distribution to the head and neck portion. But after that, giving the branches, this arch of aorta extends downward, which is called as the descending aorta. And the aorta at the level of the thorax is called the thoracic aorta. And the aorta which is coming down into the abdomen is the abdominal aorta. And then obviously at the level of L1, this bifurcates into the common iliac vessels or the common iliac arteries, which ultimately divide into internal iliac and external iliac arteries. Now, if you could appreciate in this diagram, this is the arch of the aorta, obviously the vessel which is extending from the heart, and this is the part of the thoracic aorta, and this is the abdominal aorta, as I have already explained you about this. If you could appreciate here in the figure B and C, so you can see that there's a kind of the dilated portion which is involving the thoracic part of the aorta. So there's a thoracic aortic aneurysm. If you could appreciate this in the C part of the diagram, this is the abdominal aortic aneurysm, and most of the time this abdominal aortic aneurysm is just infrarenal, and it's a region which is extending from the origin of the renal arteries to the origin or the division of the aorta into the common iliac vessels. Now, since it's kind of the image about the aneurysm is quite clear to you guys, we'll be talking about the category or the classification of the aneurysm. So you should remember that the dilatation of the localized arterial system greater than 50% is called as the aneurysm, and it can be anywhere. There can be involvement of the brain, and there can be involvement of the thoracic aorta. There can be involvement of the abdominal aorta. So if we talk about the thoracic aneurysm, the cause behind that is obviously most of the time the collagen vascular diseases and Marfan syndrome, Ehlers-Danlos syndrome most of the time. But if we talk about the abdominal aortic aneurysm, the cause behind this most of the time is it's obviously the smoking, the first and the foremost important cause, and obviously the increase in the intra-abdominal pressure. So if you could see about the classification, so we actually divide this classification into three big categories. One is the differentiation on the basis of the wall. If there's a true wall, this is a true true aneurysm. So the true aneurysm is the one which is consisting of all the walls of the arteries. So we all know that the arteries, they're composed of three walls: the intima, media, and the adventitia. So the innermost layer is the intima, which also consists of endothelium and the basement membrane. So this endothelium and the basement membrane, they constitute the inner layer of the vessel, which is called intima. In between the adventitia and intima, there is a layer of which is comprising the smooth muscles, and that's particularly called as the media. So most of the time, the contraction, the dilatation, and the relaxation of the vessel is because of the contraction and relaxation of the smooth muscles which are present in the media. And the most external layer is called as adventitia, which mostly is comprising of the connective tissue, giving a kind of the strength to the wall. So let me tell you here that out of all these three layers, intima, media, and adventitia, the adventitia is comprising of the fibrous connective tissue. So the most of the strength of the wall that depends upon the adventitia. So because the aneurysm most of the time is because of the weakened wall of the artery. So we actually divide this into a true aneurysm and a false aneurysm. So the true aneurysm is the one which is consisting of all the three layers, like the dilatation is involving intima, media, and adventitia. And the false aneurysm, usually after the traumatic incident, there's a dilatation of one of the wall, and most of the time it's a fibrous connective tissue. So that's called as the false aneurysm. We also divide these aneurysm on the basis of the location, on the basis of their morphology, like you divide them in a fusiform and a sqadia aneurysms on the basis of their shape. And sometimes you also divide them on the basis of the location, like if there's an involvement in the thoracic aorta, so this is a thoracic aortic aneurysm, and there's involvement of the abdominal aorta, this is the abdominal aortic aneurysm. And then you also classify these on the basis of etiology, like most of the time, what is the cause? The cause can be the collagen vascular diseases, the cause can be infective, the cause can be traumatic. So actually you divide them into atheromatous, like because of the intima becomes weak, as the deposition of the cholesterol and the formation of the atheroma, there is a weakening in the vessel wall, and that leads to the formation of the aneurysm. We also divide them into another category, which is called as mycotic. So the mycotic is actually, that's a kind of a monomer. Now, but because they're not somehow related to the fungal infection, so that's why that's kind of a mismonomer. So the other cause behind all this is the collagen vascular diseases, because we all know that actually the fibrous connective tissue, which is present in the adventitia, and it's giving kind of the strength to the muscle wall, is mostly composed of the collagen type 4 and collagen type 1. So all those diseases in which there is a kind of problem with the collagen development and the formation of the protein, the collagen, there would be some kind of the wall weakness, as in the Marfan syndrome and the Ehlers-Danlos syndrome. So actually, you should remember that the classification is broadly categorized into three types, one depending on the wall, if it's a true wall or a false wall. So the true walls is the one which is containing all the three layers of the vessel, like intima, media, and adventitia. And the false, obviously, that contains a single layer, and most of the time it is kind of the connective tissue or the fibrous trauma. If we talk about the morphology, it means that you are dividing them on the basis of the shape. So it can be secular, it can be fusiform. And on the basis of the etiology, it can be atheromatous, it can be mycotic, there have been collagen diseases, and the other category, which includes the traumatic causes for that. So if we particularly talk about the abdominal aortic aneurysm, so if you could appreciate in this diagram that most of the time They're most common in the male, usually middle-aged male who are chronic smoker, because actually, the smoking is the main culprit behind, and it weakens the wall. Like if we talk about the thoracic aortic aneurysms, so most of the time they are more somehow related to the inherited defects. They're related to the collagen vascular disease like the Marfan and the allodenal. So other than that, if we talk about the abdominal aortic aneurysm, the most important cause would be the smoking. The first and the most common important cause would be smoking. And the other causes like the collagen vascular diseases, they also somehow contribute, but they're more related to the thoracic aortic aneurysms as compared to the abdominal aortic aneurysms. And the mechanism behind this, that there is more association with the thoracic aortic aneurysm as compared to the abdominal aortic aneurysm, is still unknown. But the thing which you need to remember is most of the time, this aneurysm is extending infrarenal part of the abdominal aorta to the bifurcation of the of the aortic abdominal aorta into the common iliac vessels. So if you could appreciate in this diagram behind that, this is the part of which from which the abdominal aorta is giving rise to the renal arteries on both sides. So it is infrarenal and it's extending down to the point where the aorta is divided into the common iliac vessels. So remember the location starting from the infrarenal vessels extending to the bifurcation of the aorta. So most of the time these the patient is asymptomatic, but sometimes the patient can present with a severe abdominal pain, and this pain is actually radiating to the back. Now, we actually divide these symptoms like the features. The patient remains asymptomatic, then the patient remains symptomatic but stable, and the patient in which there's a ruptured aortic aneurysm, so they actually present with the episodes of the hypotension and obviously severe abdominal pain and the pulsating abdominal mass. So usually this is a kind of the incidental finding. In fact, whenever you're trying to perform the ultrasound abdomen, and on the incidental finding you have got the abdominal aortic aneurysm, so in asymptomatic patient it's a kind of the incidental finding. But now there are some kind of the indications. If you are you found out that the patient who is actually asymptomatic, but you have found out to have the abdominal aortic aneurysm. Now the diameter of the aneurysm is somehow very, very much important. If the diameter is less than 55 millimeter, then usually, and the patient is asymptomatic, there is no need to repair that. But if the patient becomes symptomatic, and even if the patient is not symptomatic, but the diameter is greater than 55, then surgery should be considered, because those the aneurysms, which are usually they have a kind of a larger size, there's more chances of the rupture, and rupture aortic aneurysms has got a morbidity, a very, very bad morbidity and mortality, and the mortality intraoperatively is 50%, and the mortality during the hospital stay is 90 to 95%. So if you want to save the patient, then almost all the abdominal aortic aneurysms in which the diameter is usually greater than 55 millimeter, then surgical repair should be considered. We'll be discussing how to repair the abdominal aortic aneurysm. We'll be talking in detail later on. But the thing is this, that you should keep in mind the patient who is asymptomatic and the diameter is less than 55 millimeter, then there is no indication of the surgery. But if the patient is symptomatic and the diameter is greater than 55 millimeters, then the surgery should be considered. And all those abdominal aortic aneurysm whose diameter is greater than 70 millimeter, they should be and they must be repaired, because there are more chances of the rupture as the size of the abdominal aortic aneurysm increases. Now, there's another important thing which you need to know, that age of the patient is somehow very, very much important, because as the process of the aging goes on, there's a more and more dilatation, or there's an increase in the size of the aortic aneurysm. So all those patients who are, they're middle age, or they're in the extremes of their age, they should be operated, especially those who are above 50, and the diameter there's a chance that with the increasing age there would be change in the diameter, they would be increase in the diameter, then obviously the surgical repair should be considered. So, like sometimes those patients who are symptomatic, they can actually, I have told you that there are three categories. One are asymptomatic, and there is a symptomatic, in which there's a dull ache, pain, and the patient usually complains of on and off pain. But sometimes when there's a ruptured aneurysm, and the patient will obviously present to you with a severe abdominal pain which is radiating to back, and obviously the patient will be hypotensive, and because there would be internal bleeding going on. And now the aortic aneurysm can rupture anteriorly into the peritoneal cavity, and it can rupture in the posteriorly, which is the retroperitoneal space. So if it's involving the most of the time anteriorly, the patient will complain of severe pain, or there will be more of the hypertension, and there will be signs of the peritonitis. But if it is leaking behind, or there's a rupture in the retroperitoneal, so because of the limited space available in the retroperitoneum, sometimes the hemorrhage becomes concealed, but still the anterior a rupture is more common, like the 20%, but there is more of the mortality associated with the anterior rupture of the aortic aneurysm. And if we talk about the posterior rupture of the aortic aneurysm, they are more common, they're 80%, but their association with the mortality is less as compared to the anterior rupture. So now, if you, on the basis of the history and examination, and on the history, there's a severe abdominal pain which is radiating to the back, and obviously, since the patient might give you that he might have the history that there was the ultrasound done, and there was a abdominal aortic aneurysm that was small at the diameter, and he'll be telling you the details. But sometimes if the patient is not aware of the fact that he has got the abdominal aortic aneurysm, and still it's a kind of incidental finding, and there's a pulsatile mass in the abdomen, then always think about the aortic aneurysm. And if there's a pulsatile mass, there's a severe abdominal pain, and there's a hypertension, then think about the ruptured aortic aneurysm. So if the patient has come to you with all these symptoms, and you have found out that the patient has got a pulsatile abdominal mass, then how you are going to proceed? Obviously, you need to go for some investigation. So you start from the very baseline investigation. You go for full blood count. If the hemoglobin level is very low, maybe 7, maybe 8, you'll suspect that there's an internal hemorrhage going on. You need to order for the electrolytes, you need to order for the liver function test, the coagulation profile is somehow very much important. All the baseline investigation, they should be carried out, they're important. Then obviously the blood lipid estimation, why this is somehow important, because most of the time, if you talk about the abdominal aortic aneurysm, so there are atheromatous plaques, which actually they weaken the process of the atherosclerosis. They weaken the wall of the vessel. So actually, there would be high cholesterol levels in case of the abdominal aortic aneurysm. The ECG is also somehow very much important, because the patient can develop infarction, ischemic infarction, in case of the abdominal aortic aneurysm, and there would be, obviously, the patient is bleeding, the cardiac output will increase, and there would be stress over the heart. So that's how somehow that's important. Chest radiographs, isotope ventrillography is somehow important. The cardiopulmonary exercise testing and spirometry, these are all important investigations which need to be carried out in case of the when you're investigating the case of abdominal aortic aneurysms. Now, sometimes if there is abdominal aortic aneurysm, the patient is only complaining of the pain, and then you need to investigate all these things. But if if there's a ruptured aortic aneurysm, then obviously that's a kind of the emergency, and ultimately what you do is you need to rush to the operation theater, and you need to arrange a lot of the blood, resuscitate the patient, and do the repair as soon as possible. So, but these investigations are for the routine cases of the abdominal aortic aneurysm in which ultrasound abdomen was done, and on routine, there was incidental finding, or maybe the patient was complaining of the dull pain, and you felt to have the pulsatile mass, and they were investigated, and that came out to be aortic aneurysm. Then what other investigation you need to order? It's a full blood count profile, electrolytes, liver function test, coagulation screening, blood lipid estimation. Obviously, ECG is somehow very much important. Chest radiographs, isotope scanning, cardiopulmonary exercise testing, and spirometry. These are all important investigations. Now, what kind of the information these radiographs are actually going to give you? Now, important thing is this, that you need to go for a CT scan. You need to go for the MR, which is the magnetic resonance MRA. That is kind of the angiography. And you need also to go for the duplex scanning. So if you could appreciate in the diagrams, there are two radiographs. One is actually the CT scan, and other is the MR angiography. So actually, this is the part of the aorta, and you can see that there's a dilated aorta which is present in the center, and you can appreciate this is the lesion, very hyperdense lesion, which is actually showing you the aneurysm which is present in the aorta. So this is the CT scan of the abdomen, and at this level you can appreciate the aorta, and this hyperdense area, the whitish is in color, this is actually the abdominal aortic aneurysm. The other radiograph is about the MR angiography, and you could see actually in which in the magnetic resonance angiography which you give the contrast, and if the renal function tests, they're perfectly fine. You order for the contrast, and you can see the imaging, right? So this is the origin. These are the kidneys, if you could appreciate here in this diagram, and these are the renal arteries which are originating from the aorta, and they're giving supply to the kidneys. And this is the part of the abdominal aortic aneurysm. I have already shown you this in the other picture, but there's a real radiograph showing you. And obviously, this is the part of the the abdominal aortic aneurysm, which is extending from the infrarenal vessel and extending to the bifurcation of the aorta into the common iliac vessel. So this is the most common location of the abdominal aortic aneurysm. So always remember, you go from simple to the complex. So initially you would be investigating like all the baseline investigations like the blood CP and RFTs and liver function tests, lipid profile, and ultimately you have to go for the CT scan to identify the location and the extent and obviously the diameter of the aortic aneurysm, and then you have to go for the MR angiography, giving you the pinpoint extension of the aneurysm, and then ultimately the duplex scanning is somehow very, very much important because it's a kind of the gold standard for the abdominal aortic aneurysm. So there's another diagram. It's a kind of a more clear part, and it's actually extending infrarenally to the bifurcation of the common iliac vessels. So angiogram is somehow very much important again. This was the duplex scanning and the magnetic resonance angiography, and you can see here this is also the angiogram, which is actually in which a contrast is being given. A femoral, this is the femoral. This is a kind of the catheter, and in this catheter, actually, what you do is the catheter is inserted through the femoral artery, and the contrast is given through that catheter, and the angiography is being performed in the abdominal aortic aneurysm is quite visible in this. Now, somehow the repair of the aneurysm, there are two important things which can be done. One is the open aneurysm repair, and the other one is the endovascular, like minimally invasive. So with the development and with interventional cardiology and with the intervention of radiology, minimally invasive surgeries, they are performed more routinely because they are kind of less time consuming, and they give you more better result, and their association with the mortality is lesser as compared to the open, and the visualization is somehow more important, because in case of the endovascular repair, all the time you are monitoring each and everything. You're inside the vessel, the catheter inside the vessel, and you do the stenting through that. So for the peripheral vessels, again, you do the same, like the procedure for the peripheral vascular disease, the stenting and the balloon dilatation. They are somehow similar to the endovascular repair of the aneurysm. So if we talk about the open repair, so this is the part of the aneurysm. So how you actually proceed: you prepare the patient and you give a midline incision. A transverse incision can be used, but most of the time, whenever you're working in a vessel, as a general rule, you can use both the incision, the transverse and the vertical incision. But vertical incisions, they're preferred more because the proximal and the distant extents, they are more visible as compared to the transverse incision. So you actually give a midline incision, and obviously the whole of the intestine is retracted to the right or the left, and you just enter the retroperitoneum, and then you enter the abdominal aorta, and then the aneurysm is if there's an aneurysm and it's bleeding, or even if there's aneurysm which is not ruptured, what you do is you give the clexine or the heparin intraoperatively, the systemic heparin, and then you clamp the aneurysm. After the aneurysm is being clamped, after clamping, the aneurysm is being separated, dissected, and this is a prosthetic material which is being used, and it is kind of the prosthesis graft. So this prosthesis graft is actually placed in between the part of the aneurysm, and it is sutured with the proximal and the distal part of the aorta. And then obviously after the repair, the sealing, and after if there's a retrograde flow from the renal and the mesenteric vessels, then you're confirmed that the aneurysm is being treated and repaired in a very effective way, and then you obviously close the sutures and close the abdomen and skin, and you also put a drain. So the repair is like this: abdominal aortic aneurysm. You open it. Obviously, the midline incision is given. And after giving the midline incision, the proximal and the distal extent of the proximal and distal extent both are marked, and the intestine is retracted to either right or the left side. The retroperitoneum is being reached, and you enter the abdominal aorta. You apply the clamps. You separate the aneurysm. You incise the part of the aneurysm, and proximally and distally, and then this is the prosthetic material, the kind of the prosthetic graft, and this graft is being sutured in between the proximal and the distal part of the aneurysm after the excision, and that's how it's being sutured in between, and the flow is restored, and it is checked through the retrograde flow of the mesenteric vessels and the renal arteries. That's how you perform the open aneurysmal repair. So in case of the endovascular prosthesis, you can appreciate here, these are the endovascular prosthesis available. So how you do you approach through the femoral vessels, and through the femoral you go upward, and obviously the femoral, the common iliac, and then you go from distal to proximal, and the part of the aneurysm is being reached, and then you put these endovascular prostheses in between, and it is a kind of the minimal art and minimal invasive surgeries by a very small incision, and you go retrograde, and obviously you are doing all of the surgery under direct visualization in the camera. So today these procedures, they are more favorable. They're performed routinely, and they're with the interventional radiologist and the interventional cardiologist. So there's another, the endovascular repair, aneurysmal repair. This is the red part. This is a kind of the duplex scanning of the Doppler ultrasound, and it's actually telling you about the flow when this is the kind of the prosthesis which is being placed. So in case of the repair, the angiogram is performed, in the routine, and the contrast is given through that femoral catheter, and obviously whenever you're done, then the closure is done after you're satisfied with the correct placement of the prosthetic material. There's an important thing which is very, very, significant, and it should be discussed in detail, like the ruptured aortic aneurysm. I have been discussing about the ruptured aortic aneurysm in between the previous slide, but if we talk more about the management, this is a kind of a surgical emergency, and because the patient is, there can be anterior rupture, there can be posterior rupture. So anterior rupture is 20%, and posterior rupture is 80%. But the anterior rupture is more somehow has got the more risk of the complications because the patient is bleeding in the peritoneal cavity. And in case of the posterior rupture, the patient is, the hemorrhage is concealed, and usually, the hypotension gives you the time to reach to the hospital. So the anterior rupture has got a very, very bad mortality, and usually these anterior rupture aortic aneurysm, they do not give you the time so that the patient should be transported to the hospital. But the posterior, they are more common, like 80%, but they have a kind better, less risk of mortality as compared to, at least because the hemorrhage is concealed, and the hypertension is not that severe, so it gives you time so that the patient could be transported to the hospital. So if we talk about the management, early diagnosis is the key. If the patient has complaint of severe abdominal pain in the center or radiating to the back, and the patient is hypotensive, and there's a pulsatile abdominal mass always and always, it's a clinical diagnosis. You don't have to wait for the CT and the MR and everything, but it's a kind of a emergency, so it's a kind of a clinical diagnosis. So early diagnosis is somehow important. Immediate resuscitation, pass the 2 large IV cannulas, give fluids as much as possible, resuscitate, 6-pack units of the RBCs or the whole blood should be made readily available, and patient should be transported to the hospital as soon as possible and shifted to the operation theater to repair. You have to maintain the systolic pressure, in less than 100 millimeters of mercury. You don't have to resuscitate the patient with a lot of fluids and extending or increasing the pressures to 140 and 130. You have to keep 100 of the systolic pressure. Catheterize the patient. This is somehow very much important. Monitor the urine output. Cross match should be sent. 6 units of the blood should be arranged, and rapid transport to the operating room. So early diagnosis, immediate resuscitation, a lot of fluids, large bore IV cannulas, right? Pack cell volume of the blood if available, pack red blood cells or the whole blood, whatever you have available. 6 units should be arranged at least. Catheterize the patient, monitor the input output, resuscitate, maintain the systolic pressure. That should be kept. like above 90. So, if we talk about the symptoms of the ruptured abdominal aortic aneurysm, abdominal pain or back pain, there can be GIT symptoms, there can be urinary complaints, there can be venous symptoms. Now, what do you mean by the GIT symptoms? Sometimes if the abdominal aortic aneurysm, that's not ruptured and there is a pulsatile mass, a huge mass in the abdomen, then obviously it's a kind of the compression to the viscera which are present in the abdomen, like the intestines, and compression on the duodenum, and causing the obstruction, kind of a vomiting, abdominal distension. So these are the GIT symptoms. And if we talk about the urinary symptoms, because it's extending infrarenal to the bifurcation of the abdominal aorta to the common iliac vessel. So what actually it does is compression can lead to the urinary symptoms, like the obstructive symptoms. The patient can complain of hesitancy, urinary incontinence, frequency. All these symptoms should be present. They can be venous symptoms, like the obviously most of the time these symptoms are because of the compression. So if there, the IVC, inferior vena cava, and the aorta, they are located side by side. If there's a large abdominal aortic aneurysm, it's compressing the IVC, inferior vena cava, then obviously there would be the edema of the lower limb, because of the compression, the drainage wouldn't be that efficient. So that can lead to the venous compression and symptoms of the pedal edema and the lower limb edema as well. So if you're already you have you on the base of the history, the clinic examination, the diagnosis was made to have the abdominal aortic aneurysm. So in case of the abdominal aortic aneurysms, what actually you do, a repair has been done, there can be some post-operative complications, and you need to take care of all these things: ischemia, infarction, particularly the myocardial infarction, myocardial ischemia. If we talk about the urinary system, then there can be an effect on the kidneys. So like if the patient has bled so much, and there was a hypotensive episode for a very long time, so there can be a possibility that there would be the hypoperfusion of the kidney. So because of the hypoperfusion of the kidneys, the kidneys can go into the acute renal shutdown. There can be atelectasis, there can be lower lobe consolidation, renal failure, sexual dysfunction, spinal cord ischemia, because most of the time the branches are just coming from the abdominal aorta, and if there's a leakage or the rupture of the abdominal aortic aneurysm, all these complications can be developed: aortoduodenal fistula, prostatic graft infection. This is a kind of the infection. So even if you're done with the repair, you have saved the life of the patient. Always take care of the post-operative complications: ischemia, infarction, monitoring, ECG monitoring should be there, atelectasis, lower lobe consolidation, renal failure because of the hyperperfusion, sexual dysfunction, spinal cord ischemia, aortoduodenal fistula, prostatic graft infection. These are all the post-operative complications. So this was about the abdominal aortic aneurysm. There are other aneurysms as well, which can be anywhere, like the popliteal aneurysm, like the femoral aneurysms. And if we talk about the popliteal aneurysm, so most of the time the patient will complain of severe leg pain, most of the time in the popliteal fossa. And even if this aneurysm is compressing the structures, there can be a pain in the lower limb, and there can be, because of the compression, the popliteal arteries actually supplying the branches like the tibial, the peroneal, and the posterior tibial. They're coming from the popliteal arteries, so the blood supply of the lower limb would be affected, and because of that, there would be, the signs and symptoms of ischemia, and there would be sometimes the patient can develop gangrene. So actually, this is the popliteal artery is actually behind the knee, so in the popliteal fossa. So there would be a swelling in the knee that can extend above or below the knee. That depends on the aneurysm, the length of the aneurysm, and the diameter of the aneurysm. And because the aneurysm is also compressing the branches of the popliteal artery. So there would be vascular compromise, and obviously there would be diminished pulses distally. So that's how the popliteal aneurysm is going to affect and present to you. Now, important thing about this aneurysm is obviously the management. So usually there are three procedures which are used, but commonly two procedures are used. One is exclusion bypass and inlet repair. Inlet repair, it was, that was used to perform in the past years, but usually today the exclusion bypasses, they're more common and they're more favorable in today's setting. So if you could appreciate in the diagram, this is the popliteal aneurysm, which is being present in the popliteal artery and the popliteal fossa. And this is the kind of the prosthesis or the graft which is actually present, and the aneurysm is being excised from that. And this excision is kind of the even if after the ligation of the aneurysm, as you could appreciate, there's the proximal and the distal part is ligated and is separated, and a bypass is created. It's a kind of a shunt. So if still the aneurysm is present, what you need to do is you need to get the proximal and the distal control of the aneurysm. And after getting the proximal and the distal control and then ligating the proximal and distal part of the aneurysm, what you do is actually you take a bypass graft, and usually the graft is taken from the long saphenous vein. And whenever you are grafting a vein to the artery, you need to invert the direction because of the valves. So what you do is you graft that patch of the vein, mostly the long saphenous vein, in a reverse manner into the artery, and it's kind of the bypass. So there was an aneurysm. You get the proximal and the distal control, and you ligate the proximal and distal part, and then obviously what you do is you put the bypass graft. It's a popliteal artery bypass graft. And sometimes there are other aneurysms as well, like the femoral and the iliac aneurysms. They can be present, if you could appreciate in this diagram. This is large femoral aneurysm. The femoral artery is present in the femoral canal. And if you talk about the structures associated with that, is like vein, artery, and nerve from medial to lateral. So artery is in between the vein and the nerve, and you could appreciate here that this is a large femoral aneurysm, and in the similar manner you perform the popliteal artery bypass graft. So you do the femoral artery bypass graft, and this is the iliac aneurysm and after the bifurcation in the common iliac vessel. So same is done, a bypass graft. You ligate the aneurysm, you get the proximal and distal control, and then you put the bypass graft. As you could appreciate, this is the aneurysm. Now the aneurysm is being excised and separated, the proximal and the distal. The part is clipped or repair, which is basically that, or sometimes after that the proximal and the distal part is ligated, and this bypass is created in case of the femoral artery bypass. So this was about the aneurysm. Few more things we need to discuss here is about the arteriovenous fistula. It's like the abnormal connection between the artery and the vein. So you can see and you can there can be traumatic formation of the AV fistulas. There can be AV malformation congenitally or because of the developmental errors, or in case of the CKD patients in which the dialysis need to be performed, you make the arteriovenous fistula by choice, because it's you could appreciate, this is the artery, this is a vein, and there's an abnormal connection between the vein and the artery. So this it is a kind of the arterialization of the vein, because the veins, they're not very elastic, and they're not very strong. Their strength as compared to the artery is less, and the arteries, they because of their vascularity, because of their elasticity, because of their strength, they can actually tolerate the higher pressures. So in the AV fistulas, which you make in the CKD patient, the purpose is that because when you are putting the patient on dialysis, most of the blood is a very high pressure blood. And obviously, you need to arterialize the vein so that the high pressure blood should be sustained. So there can be AV formation, AV malformation. There can be traumatic formation after the traumatic incidents. There can be formation of the AV fistulas, and sometimes you make AV fistulas as a need in case of the CKD patients. There's some other conditions which are the vasospastic conditions, and like arthritis and vasospastic conditions. So one is a thromboangiitis obliterans, is a kind of the vasculitis of the small and the medium-sized arteries, and because of that, it's affecting. It can be, it can affect the arteries involving the lungs. It can affect the arteries involving the renal vasculature, and it is also associated with a Raynaud syndrome. There's another arthritis which is called as a temporal arthritis, in which usually the giant or the larger size arteries, it's a vasculitis of the larger size arteries, and most of the time it's involving the temporal artery, and the patient complains of severe ipsilateral or unilateral headache, which can be associated with the diplopia and sudden loss of the blindness if it's involving the ophthalmic artery. Takayasu arthritis is again a kind of the type of the vasculitis, which is involving the medium and the larger size arteries. Cystic myxomatous degeneration, it's a kind of the within the vessel wall, there's a clear jelly-like substance which is being deposited. It's like a ganglion, and you could there's a vessel wall, and you can appreciate there is a small cystic area in which there is a myxomatous degeneration. It's a clear jelly-like substance as just like to the ganglion. There can be Raynaud disease. It's more common in the cold, and some people when they're exposed to the cold, their digits, most of the time the digits of the fingers hand, they get discolored, they get bluish in color, and this is because of the vasoconstriction. So sometimes there's a severe pain, and later on there is redness, there's dusky coloration, there's swelling of the digits. So initially, the cyanosis of the extremities or the digits, they develop because of the vasoconstriction, but later on, because of the dilatation of the capillaries, there's more of the flow, and because of that, there's a swelling, permeability of the capillaries increases that lead to the edema, and the limb becomes swollen and sometimes dusky as well. So for all those patients who undergo this Raynaud phenomena, it's a kind of the vasoconstriction. The vasodilators are given, the calcium channel blockers particularly, they're very much important, and the temperature extremes, the moderation or the adaptation with the atmosphere, this is somehow important. The Raynaud syndrome is a kind of this, it's somehow related to the disease, but it's not specific to one system. It's also associated with the systemic lupus erythematosus or rheumatoid arthritis, a kind of the autoimmune diseases, and there's some kind of the other diseases as well, which are vasospastic, including the acrocyanosis. So in all these vasospastic conditions, first you try to treat them conservatively, giving the calcium channel blockers or the vasodilators, or for the severe excruciating pain, cervical sympathectomy that was used to be performed in the past, because if we talk about the Raynaud disease or the syndrome, most of the time the upper limbs are involved, and the branches coming from the cervical plexus, they actually supply the upper limb. So what happens is, like, cervical sympathectomy is usually performed to relieve the pain in case of the vasospastic conditions, but is somehow no longer indicated. There's some kind of the ganglion, as a stellate ganglion you could appreciate. There was a lumbar sympathectomy, which is usually performed in the past, but it's somehow for the chronic lumbar pain, usually sciatica, But now there are other non-invasive procedures which can be used to treat these vasospastic condition instead of doing a lumbar sympathectomy, right? So this is actually the dorsal root ganglion at the altiolumbar vertebra. So actually in that sympathectomy is performed, a ganglion blocker is inserted, and that's how this is the catheter, and the catheter, through that catheter, kind of the blocker or the the anesthetic agent is usually given through this this epidural, or the spinal needle, and the ganglion is loaded with the whatever, it's a kind of a local but a short a longer duration anesthetic can be used in case of the lumbar sympathectomy. And actually it blocks the posterior rami of the spinal nerve, and because actually the ganglion is it's giving rise to the posterior and the anterior rami of the spinal nerve. So whenever you try to block the that particular ganglion, the posterior and the anterior rami both are blocked. So that's a kind of modality which is being used for the chronic pains because of the neuropathic or the vasospastic conditions. It's somehow no longer indicated in today's setting. So that's all for today's lecture. We have been discussing about the abdominal aortic aneurysms, thoracic aortic aneurysms. They're obviously the open repair and endovascular repair as well. We discuss about the femoral and the popliteal aneurysms as well, and at the end we try to discuss the other vasospastic conditions. So thank you for watching.